everyone, this is Fabiola Medeiros presenting for Pathologists Online on the topic of placental pathology. I'm the Director of Gynecologic Placental and Perinatal Pathology at Cedars-Sinai Medical Center in Los Angeles, California, and it's really an honor to be here sharing our experience in placental pathology with all of you that are watching. So in this session, we're going to cover maternal vascular malperfusion, fetal vascular malperfusion, hypervascular lesions, and some rare conditions that occur in the placenta. Let's start with maternal vascular malperfusion. Before we understand what happens in maternal vascular malperfusion as a disease, we need to understand what normally happens in the placental bed during the progression of pregnancy. There is a phenomenon that is called physiologic conversion. This is a normal phenomenon that occurs in most pregnancies. When that fails to occur, we see the development of decidual arteriopathy. The most common findings that we see on the slides are fibrinoid necrosis of decidual vessels and acute atherosis, while mural hypertrophy of spiral arterioles is something we see quite uncommonly, and all of these processes are seen within the decidual capsularies. It is also difficult to find deficient remodeling of spiral arterioles, even though that's one of the diagnostic criteria. Laminar decidual necrosis is not per se decidual arteriopathy, but it does indicate ischemic changes in the decidua, and some experts believe that this could be associated with the whole constellation of maternal vascular malperfusion. When we look at the parenchyma per se, there are two subtypes of ischemic changes that we see in the parenchyma. The so-called global partial maternal vascular malperfusion and segmental complete. I think it's helpful to think of maternal vascular malperfusion in these terms. So global is chronic partial decrease in maternal perfusion, and that's histologically characterized by accelerated villus maturation, increasing C-shell knots, and distal villus hypoplasia. While segmental complete is characterized by infarcts and are a result of sudden complete loss of maternal perfusion in one portion of the placenta. In this table, I summarize most of the parenchymal changes we can see in the setting of parenchymal ischemia. The top half are the ones that we see more commonly and that are more diagnostic. Some of the others towards the bottom, some of them are controversial, like trophoblast pseudocysts, and some others you actually need quite a volume of disease to be able to interpret them as parenchymal ischemic changes. Now I'll be sharing some slides, some virtual microscopy to understand how these lesions look like. So this is a membrane roll, which actually has a lot of decidua, and we, even on low power, already see that these vessels look abnormal because they're dilated, ectatic, and they're very prominent, and usually in the decidual capsularies we don't see these vessels very well. They tend to be quite small. Then when we look closer into the decidual vessels here, we see that the wall of those vessels is replaced by fibrinoid necrosis, which is this very pink, like very bright pink color. And in addition, we have these foamy cells, which corresponds to acute atherosis. And we have some more of them right here. So let's see if we find some other vessels that are characteristic. Again, this is very characteristic. It's so bright pink. So those are vessels that have fibrinoid necrosis of the vessel walls. Quite convincing. And then the second subtype that we don't see very often is only the mural hypertrophy. So in mural hypertrophy, the vessels have thick muscular walls, but they do not show fibrinoid necrosis. So here on the left, this is quite normal. It's kind of difficult to find the decidual vessels, but when we come to the center of the screen now, we see that these arterioles are very thick with a compressed, like a very constricted lumen, and this is actually quite close to the chorion and amnion, indicating that we are actually at the decidual capsularis. When you go deeper down into the decidual parietalis, you may see some thicker vessels, but this is very close up to the chorion. So this is mural hypertrophy of decidual vessels. And then finally, the third example I would like to show you is laminar decidual necrosis. So in laminar decidual necrosis, the decidual will be necrotic pretty much. So let's find a little bit of normal decidua, which of course would look like this. But then as you can see, this portion of the decidua shows this very pink type of necrosis. And as we cruise along the membrane row, we see more and more of laminar decidual necrosis here. Again, this is still sort of a controversial entity, but when it's extensive, like in this case, I do believe it's quite good evidence for ischemia, in this case, ischemia of the maternal decidua. So now let's move on to the parenchymal changes, and one of the most characteristic ones is increasing syncytial knots, and this is a case that shows very convincing increase in syncytial knots. So first you have to decide where you are in the placenta, right? Here is the chorionic plate. Well, it doesn't show very well in this section, but this is the top fetal surface, and then we move down until we actually reach the basal the decidual basalis and the basal plate. So as we can see, villi from pretty much everywhere we look, they have increased syncytial knots, and that's defined by more than 30% of the terminal villi with knots, and not only that, the knots are very large with more than 10 nuclei, and another criterion is also more than one knot per villus, and we do have several examples here. So this is unequivocal increase in syncytial knots, pretty much unequivocal parenchymal ischemia. And then you may say, oh, but it's a 42-week post-term placenta. It doesn't matter. At any gestational age, this is abnormal. One pretty extreme form of maternal vascular malperfusion and ischemic parenchymal changes is distal villus hypoplasia. So again, here, unfortunately, I don't have the basal plate, but this is the chorionic plate here at the top, right here. So as we go down, by the way, below the chorionic plate, it's normal to have a histologic picture of villus hypoplasia because this upper 1/3 of the placenta is naturally ischemic. But as you go to the mid third and the lower third, you should have a more normal appearance. So this is a very characteristic of distal villus hypoplasia. First, we have villosposity and a lot of empty spaces. And then the villi themselves, they have some characteristics. First, they are elongated. A lot of them are elongated. And you have a lot of isolated syncytial trophoblastic cells within the intervillus space. Some villi are extremely small. So those are all features of distal villus hypoplasia that we see here in this slide. And this is ischemia that occurs earlier on in pregnancy. That makes basically causes failure of villi to develop properly. And then, of course, everyone is familiar with an infarct, right? So what's the definition of an infarct? This is an infarct. Usually they are based on the basal plate, as we can see here, and wedge shaped. They pretty much by definition are well circumscribed lesions. So we see this lesion is well circumscribed, right? The hallmark on intermediate power, and that's something you should see in every case, is collapse of the intervillus space. So when we look at those villi, they are aggregated, right? There is some fibrin in the intervillus space, but overall, there is villus agglutination here. There's decrease, there's collapse of the intervillus space, and that's characteristic of an infarct. The main differential for an infarct is something that we call increased perivenous fibrin deposition, which is this case here. In this case, we have areas that look abnormal, like this one in the center. When we look closely, the villi are not collapsed on themselves. Instead, we have increasing perivenous fibrin, which is this pink material here between the villi. The villi themselves are also necrotic, but this is a separate, although can be also considered ischemia when there are extensive areas like this. But also notice is not well circumscribed, right? This one is kind of patchy. So this is increased perivenous fibrin deposition. And I think the definition is 10% of the parenchyma. It's indicative of ischemia. Now we are going to move to talk to another topic, which is fetal vascular malperfusion. So fetal vascular malperfusion, the pathophysiology behind it is basically decreasing venous outflow out of the placenta to the fetus, which this venous stasis leads to thrombosis of the fetal vasculature that then leads to some patterns of parenchymal injury. So that's the basic pathophysiology. When we look at conditions that predispose to fetal vascular malperfusion, there are many of them, actually, as you can see from this table from this relatively recent published book. But the main one that we have to remember are umbilical cord conditions. And a lot of people, and me included when I was early on, when I was a resident fellow, I didn't pay too much attention to the umbilical cord. Umbilical cord is actually very important because all of the blood comes in and out from the baby to the placenta and vice versa via the umbilical cord. So anything that happens to the cord is potentially pathologic. And all of these conditions that are listed here can lead to maternal vascular malperfusion, and that's something you should be looking for when grossly examining the umbilical cord. So how do we see thrombosis? There are many breakups of thrombosis, as you can see in this table. Usually you start with vascular ectasia, and then you move to thrombosis. That can be all of the subtypes, and in more severe cases you go all the way to stem-villus vessel obliteration. And what do we see in the parenchyma? The parenchyma has two main patterns that we see in intermediate and terminal villi. One is villus stromovascular caryoraxis, and the other is segmental avascular villi. And I'll be showing those on these slides. Now, there is a grading system for fetal vascular malperfusion, and I have copied the paragraph here from the Amsterdam criteria paper, which I totally recommend. If you do placental pathology, you should definitely read and be familiar with this paper. Now let's review some slides. Thrombosis, the way I like thinking about thrombosis in the placenta is, well, first, where is the thrombosis, right? In the umbilical cord vessels. That's something you not commonly see, even though the problem is usually in the umbilical cord. We don't see commonly thrombosis in the umbilical cord, but we see thrombosis in the chorionic plate vessels and the stem-villus vessels, so the larger fetal vessels in the placenta. And in this case that I'm showing, this is the chorionic plate right here. So we are looking at chorionic plate vessels going down into stem-villus vessels, and it's quite remarkable how the lumen is pretty much replaced by fibrin. So this would be a normal vessel right here in the center. This is intraluminal thrombosis. We don't see intraluminal thrombosis that often, particularly not to this extent. But this is a very, very remarkable case of intraluminal thrombosis. And for you to call something thrombosis, it doesn't, I mean, it's just not enough to have a little bit of fibrin floating in the lumen. You want the fibrin take over most of the luminal diameter and to be attached to the endothelial cell layer, as we see in this case. The most common thrombosis we are going to see is actually this type here, which is intramural thrombosis. So that thrombus eventually gets incorporated into the vessel wall, and that's what we're seeing here. So normally in placenta there is no fibroblastic layer, subincimal layer between the endothelium and the muscular layer, but when there is thrombosis, you form this thing that is called this fibroblastic proliferation called fibrointimal cushion that we see here, and then the thrombus gets incorporated. Just the fibrointimal cushion per se is not enough to cause something thrombosis in the placenta, but it's kind of a red flag that that's what you're dealing with. So here we have an ectatic vessel with, again, fibrointimal cushion and intramural thrombosis, same thing right here. So that's what we most commonly see, and that's what you should be looking for when examining placentas. And another subtype of thrombosis that we don't see often is when the thrombosis becomes remote, because in general it's considered that intraluminal is recent, mural is subacute, and this other one I'm showing here would be remote, and that's when the thrombus calcifies. So this is a calcified thrombus, and that's considered remote thrombosis. Of course, we have some here forming pretty much replacing the endothelial layer, but this is calcified, so that's considered remote. And I believe this case has some stem villus vessel obliteration. So this is an even more severe form in which the fetal vessel is completely obliterated, as we see in this center lesion right there. And then we move on to the parenchymal lesion. So once the vessels become thrombotic, there is some outflow obstruction, and that's going to cause injury to the villi. And that's something you usually pick up on low power, like you suspect it on low power, and then you go on high power and you confirm your diagnostic impression. It's subtle, I must say, and you really have to be searching for it in order to find it. But when we look at this placental parenchyma here, we see this area in which, I mean, there isn't a lot of normal, to be honest, but we see something like this that is a little more normal. And then when we come to this area, the villi look large and expanded, and you may even think maybe it's choringiosis or it's villus immaturity. You may consider some differential diagnosis, but when we look at the villi themselves, it's quite remarkable. This is what we call stromal villus vascular characteris. So this lesion is characterized histologically by a lot of keratic debris. The first thing to undergo apoptosis is actually the endothelial cells, right? And then the stromal cells also undergo apoptosis, and we have all this apoptotic debris. That's quite impressive in this case, actually. But one thing you need to see is fragmentation of red blood cells, and that's what we see here. So we have some red blood cells that are intact, but then we have these fragments of red blood cells, and that's due to the endothelial cell injury. Here we have more of endothelial cell red blood cell fragmentation. So this is a stromal villus vascular characteris, and that's indicative of fetal vascular malperfusion, and we have a thrombotic vessel right next door, right there. Over time, this lesion evolves, so it's basically an evolution of the same lesion. This lesion evolves to segmental avascular villi, and that too is something you pick up from low power, and then you confirm on high power. So first thing you're going to see are sclerotic pink villi without vessels. That's how you see them. So if we look at an area like this, most villi have open capillaries and they're not sclerotic. But when we come over here, that's when we see that the villi are sclerotic and basically the vessels are totally occluded. You still have some keratic debris remaining, but this would be already classified as segmental avascular villi. It can be quite subtle and focal. In this case, it's much more obvious. So we have very nice contrast here between the normal villi and segmental avascular villi. Of note, both cataracts and segmental vascular villi can be seen post-mortem changes, but in those situations it's diffuse. The entire placental parenchyma looks like those lesions, while in antemortem fetal vascular malperfusion, these lesions are segmental, as we're seeing here. Some villi are normal, some villi are abnormal. And thrombosis is always considered antenatal, not postmortem, even though stem villus proliferation is something that you can also see in the postmortem setting. So you have to be careful when interpreting these findings in the setting of intrauterine fetal demise. Now let's talk about placental hypervascular lesions. There are three main subtypes: choreangiosis, choreangioma, and choreangiomatosis. The definition of choreangiosis actually changes from textbook to textbook. I try to find one that is more that is well spread, that has a more widespread use, and that definition would be greater than 10 capillaries in greater than 10 terminal villi in greater than 10 median power fields. Normal villi usually have from 4 to 6 capillaries, so anything more than that is considered hypervascular. But for you to actually call it something choreangiosis, it needs to be quite remarkable. Many experts recommend that at least some of the villi have 20 to 30 capillaries, so you don't overcall this lesion. Choreangiosis in the past was believed to be an independent, poor prognostic indicator in placental pathology, but later studies have shown that it's not an independent factor. It's maybe significant in the setting of other placental conditions. And then choreangioma, anyone that does placental pathology probably has seen one. It's basically a benign hemangioma of the placenta. It's well circumscribed. More often than not, you're going to see it grossly. And the last hypervascular lesion that you may not have encountered because it's not so common is choreangiomatosis. And this is one in which the vascular problem is mostly in the stem villi, sometimes also intermediate villi, and not in terminal villi as choreangiosis. So now we are going to review these three lesions under the microscope. So let's start with a choreangioma. Choreangioma is a benign vascular tumor. It's well circumscribed. We see here it's quite well circumscribed. We have placental parenchyma that is normal in the background. Then when we look at the proliferation per se, it's a proliferation of capillaries, pericytes, fibroblasts, quite a peculiar lesion that is not that uncommon. This next case is a case of choreangiosis. So let me find a good area. Choreangiosis, usually you're going to have to go on high power to make this diagnosis, although the villi tend to be enlarged on low power. So this is an intermediate power here, and we can already see those are terminal villi. As you can tell, they have no thick vessels. This is a stem villus right here. But those are terminal villi. They only have capillaries, and many of them have 20 to 30 capillaries. So, and everywhere you look, I mean, this is extremely convincing of choreangiosis right here. Everywhere you look, you see them. So this is quite a remarkable case of choreangiosis. Again, villi are enlarged. They have lots of capillaries, and those are the terminal villi. And that's caused by hypoxia in the maternal blood, like you see in high altitude, smoking, and some other maternal conditions. Even cardiac maternal conditions can lead to this. And finally, I think the one of quite striking too is something like this. This is choreangiomatosis. In choreangiomatosis, instead of terminal villi, the process will affect primarily stem villi. So the stem villi are very much expanded by this vascular proliferation. They become very, very large. So let's get this stem villus. How do I know it's a stem villus? Well, it's large, it has quite thick vessels, and then the stroma is pretty much taken over by capillaries, similar to what you see in a choreangioma, right? But this is choreangiomatosis right here. And choreangiomatosis can be either localized or diffuse. This is quite diffuse, and in diffuse cases, you may have fetal vascular malperfusion, and it can cause perfusion problems to the fetus and have a poor prognosis, while the localized subtypes tend to be more indolent. So this is diffuse chorangiomatosis. And finally, let's review some rare placental pathology conditions. Starting with maternal floor infarction, massive perivolous fibrin deposition. They're basically considered the same process. You see the same thing grossly and under the scope, but maternal floor infarction is more localized to the maternal floor. And this is the definition. Greater than 3 millimeters, greater or equal than 3 millimeters in 25% of the maternal floor in at least one slide. I have never made this diagnosis. I don't know if it's just uncommon or if I missed it. I hope it's just uncommon. However, massive perivolous deposition is something you cannot miss. I'm going to show a gross picture next. You'll see it's very remarkable. And there are a couple of definitions you can use for that. Greater than 50% of villi in at least one slide, or greater than 30% of the placenta grossly. There is a high association with maternal thrombophilia and antiphospholipid syndrome. This condition is associated with high perinatal morbidity and mortality. And recurrence rate is highly variable in the literature, as you can see here, 12 to 78%. I think it's quite high. The few cases that I have seen tend to be associated with recurrent fetal losses or missed abortions. This is a gross picture of a case we had recently. This one is so extensive, the entire placenta was consolidated. So there's very little normal placenta here for us to look like. It looks like almost the gross differential was like, is this just a huge infarct? Is this massive perivolous fibrin deposition? When you look at some areas like this, you actually can see the yellow material in the intervillous space, which is the fibrin. And the next one I'm going to show you under the microscope, it will be chronic histiocytic intervillositis. That's also a common, not a common, it's an uncommon cause of recurrence fetal losses and missed abortions. Along with massive perivolous fibrin deposition, it's associated with high perinatal mortality and morbidity, and the recurrence rate has been reported to be about 50%. And the final placental lesion I will be showing under the scope is placental mesenchymal dysplasia. Very uncommon lesion. 20% are associated with Beck-Whitman syndrome. The others are basically a defect in, and it's basically a defect of imprinting with androgenetic placental mosaicism. They are diploid, so even though partial mole is in the differential, they are not triploid, they are diploid, and complete mole is also in the differential. And P57 is actually helpful in those situations because it's lost only in the stroma and not in the cytotrophoblast and stroma, as you see in complete mole. So repeating that, in complete mole, you have loss of P57 immunostain in both the cytotrophoblast and stroma, while in placental mesenchymal dysplasia only in the stroma. By the way, this is a lesion that is usually clinically suspected by ultrasound and also by the fetal abnormality. It's usually not a surprise, but I think it's important that you're aware of it in case it is a surprise. This is a case we had recently. The extent of involvement of the parenchyma by placental mesenchymal dysplasia, because it's a mosaicism type of mechanism, is highly variable. What you want to look for are these vesicles. So basically those are very dilated, like those are huge cisternae that you see grossly, and that's why molar pregnancies in the differential diagnosis. But this one, actually grossly, the extent of involvement is quite limited. So we will start with massive perivolous fibrin deposition. This is the same case I showed grossly. Well, there's pretty much no normal parenchyma here, so you're clearly gonna know this is abnormal. But again, extensive infarct in the differential. So that's what I'm going to try to show you how to differentiate them. We have some more like well-preserved villi here. And it's not an easy diagnosis sometimes to make under the microscope because there's some confounding factors. First, the villi are very much necrotic, right? So this is a ghost of a villus here, another ghost of a villus here, another ghost of villus here. But notice they are not collapsed on themselves. So by infarct, by definition, you have collapse of the intervillous space, and here we do not have collapse of intervillous space. And we have lots of fibrin, so this is intervillous fibrin. But I think one of the hardest things when interpreting this is that the extravillous trophoblasts, you see this dead tissue here? Those are dead necrotic extravillous trophoblastic cells. They tend to proliferate and basically take over a lot of the intervillous space. And that may be something that may be difficult to interpret microscopically. So we have fibrin right here, and then we move to all this necrotic cellular material, and you can see the well-preserved extravillous trophoblast next door to fibrin, fibrinoid, and necrotic intervillous trophoblast. So I'm going to go one more low power so you familiarize yourself with the appearance of massive perivillous fibrin deposition. This is a mature placenta, third trimester placenta, but this is a condition you can also see in products of conception in the first trimester. So just keep an eye for that. And now let's move on to chronic histiocytic intervillositis. So this is also a case in a mature placenta, but that can also be seen in first trimester in POC. So on low power, you may think, well, this is that patchy perivillous fibrin deposition. But then look closely, okay? Go closely and see what's actually sitting there in the intervillous space. And it's not only fibrin, we also have a cellular proliferation here in the intervillous space. We see these cells here. I mean, it may be difficult at first to figure out what they are, but we see some kidney-shaped nuclei. We see some features that suggest to us that these are histiocytic cells. Look at these cells here. So very cellular intervillous process right here. And then to confirm your diagnosis, you do a CD68 immunostain. So CD68 immunostain for histiocytes, and not surprisingly, we have lots of intervillous histiocytes, which is just not normal, right? Usually the intervillous space has mostly maternal red blood cells and some very few inflammatory cells. So this is definitely abnormal. So this is chronic histiocytic intervillositis. And the last lesion we will review under the microscope is placental mesenchymal dysplasia. The placenta will look very abnormal, as we can see here. We have huge villi. This one here is a cisterna. So this is a villus that has been greatly expanded by the central cavitation of fluid. So that's what those vesicles would correspond to under the microscope. But it's not only that. Here we have another cisterna here, but we see that the villi look abnormal. So some of them look very large and irregular. Even the vasculature, look at those vessels, they're massive, right? So the whole placenta looks abnormal. And usually you have a degree of chorangiosis, and usually you have a degree of fetal vascular malperfusion as well. So here we have stem villus vessels obliteration, for example, in the center. So, I mean, it's a diagnosis you have to work up. I don't have the P57 to show you, but as you can imagine, mole is in the top of the differential for this. So this case closes our little session on placental pathology. I hope you have enjoyed and have learned about placental pathology, and thank you so much for your attention.